So this next slide, Joan, I've tried to break down the causes or the risk factors by ethnicity. I don't want to get too technical, but in short, in this study that was recently published in JAMA, they were able to identify 12 risk factors which contributed to 41% of all the dementia cases. And these 12 risk factors include low level of education, hearing difficulties, hypertension, excess alcohol, obesity, smoking, depression, social isolation, physical inactivity, diabetes, and air pollution. Okay, these were the 12 risk factors that they identified. And actually, what they found was that if you decrease these risk factors by, each of them by about 15%, you're able to reduce the risk of dementia by about 7%. And these risk factors were more of an issue in Black patients, in people of Black ethnicity. And the risk factors that had the most important or the most significant contribution to reducing the risk of dementia were obesity, hypertension, and physical inactivity in the Black population. So your Black patients who have diabetes, who also have dementia, controlling their diabetes well, getting them physically active, and controlling their blood pressure, those were the ones that contributed most to reducing the risk of the cognitive decline.
So you're saying that concentrating on these three, and maybe we could pick diabetes from that graph as well, so maybe 4 issues, we can reduce the risk of having dementia as a complication of diabetes. So if you're living with diabetes, but you concentrate on things like the high blood pressure, being overweight or obese, and physical activity, which we spoke about before, you could reduce your risk of developing Alzheimer's disease, stroke, dementia. It's fascinating because a lot of people would think that once you have dementia, that's it. There was nothing that you could have done about it to try to prevent that developing. And you've said up to 40% of dementia or cognitive decline might be preventable by addressing these risk factors.
These risk factors, that's correct.
Which is, I think, would be quite a revelation to a lot of people. And for our race, for the African Caribbean populations, those 3 things that you highlighted, and I've thrown in diabetes as well, are things that if we really concentrate on those, we can reduce our risk of also developing dementia or cognitive decline. So it's a busy slide. The light blue dots are the ones that you need to be looking at to highlight. But it's showing us some really powerful information from a large body of evidence. And this is really up to date. So thanks very much for that, Sam. Sam, I think also one of the things that was highlighted to me by a number of people who were living with diabetes and were living with dementia and their caregivers as well, is that the relationship between that person's care of their diabetes is now impacted perhaps by the dementia, because I think the other thing we have to say is that everybody's different. So everybody living with dementia is going to be slightly different. Their circumstances are going to be slightly different, although we know that they have those sort of those symptoms in common of memory loss and difficulty managing as they used to previously. But that may add some complexity now to the care of their diabetes. So things like frequency of medications, previously, this is something I have tried to avoid as a clinician, but I know some clinicians will give people medication that they take 3 times a day. Now, it may be the case that that's absolutely fine at one part of your life when you're living with diabetes, but if you're living with diabetes and dementia, that may then cause some complications to you because of that regime. you might be end up taking it sometimes 4 times a day. You might be taking it once a day. You might not take it. So it can add some complexity, and also perhaps having to give over control to somebody else within the family. Have you encountered situations like that in your practice?
Yes, Joan. It's good that you brought this up. So I chaired the Primary Care Diabetes Europe Consensus Report on managing diabetes in the primary care setting. And when it comes to elderly patients and insulin use, we have put in there that clinicians should avoid multiple daily injections simply because of the reasons you've mentioned. These patients, when they have cognitive decline, will not remember to inject so many times a day. And if they are reliant on carers to do that, that carer has to be there, several times a day to help their elderly relative to just inject their insulin. So if you have one that they can just do it once a day, that is a preferable option. And it's not just insulin, it's also to be said for other medications that they will take. I would rather they have a once daily medication than twice daily medications, or even 3 times in some cases. In this country, we're not very, fond of taking dual combinations. If we did, that probably would have been the best option. You have one pill that contains a lot of the medication that you'll be taking, so you just take one at a time. But for some reason, dual combo medications are not a thing that we like very much in this country. But if we did that, that would actually help with adherence as well.
And I think the other thing that is really important and is highlighted in the various reports that you've been involved in, Sam, is keeping somebody safe. So keeping somebody safe and well when they're in their 30s, 40s, might be different to keeping somebody safe when they're elderly, frail, perhaps, and living with diabetes and dementia. So, and I think this is something that can cause some misunderstanding with families if it's not communicated fully. That keeping somebody safe when they're frail, elderly, and living with dementia and diabetes is going to look different. So, whereas previously we would try to keep things like the HbA1c target as close to normal as possible, when somebody's frail and elderly living with diabetes and dementia, that target or goal for the HbA1c is going to be different.
I totally agree with that, yeah.
Sam, can we clarify that? Because I think you and I would know that what we call the targets, or other people might call the goals for treatment, particularly with things like the HbA1c, as somebody gets into a frail position for whatever reason, and today we're talking about dementia, when they are in those circumstances, we need to relax the targets. Now, sometimes if you're the family member or the carer of somebody in those circumstances, for most of their life, that person living with diabetes, or everybody has been focused on getting that HbA1c down to as close to normal as possible. And then all of a sudden, healthcare professionals are saying to you, it doesn't have to be as strict as it was before. And that can sometimes cause a bit of friction, I think, in terms of, okay, well, you used to say to me it had to be as close to normal as possible, and now you're saying it can be relaxed. Why? Are you not looking after my mother, father, loved one as you used to? Why does it have to be relaxed?
Other complication, Joan, is the process of relaxation. So relaxing that target will have to mean withdrawing some treatments. And the medical training that we've had has always geared towards adding treatment to help patients. So suddenly you are withdrawing treatment, especially toward the tail end of life. The impression is created that you are giving up on this patient, but you are not. I think it's about communicating the reasons behind your decision with the patient, that if you have dementia, you are frail, you are elderly at that age, having those tight targets are actually more harmful than not having that. And if you communicate it properly and you then decide to de-intensify or withdraw some medications, carers and patients will appreciate that.
Yeah, and I think it's so important. I mean, we've raised this previously with other subjects. It's so important, that communication, that people understand the rationale and the reason why. It's absolutely not giving up on that person's care. It's the fact that it's actually now safer for that person to be at a sort of slightly higher level of HbA1c than it was previously. And so, yeah, I think that's definitely important, that we are always clear with a person living with diabetes and their loved ones and carers.
Yeah. So this one is just a basic guide to help clinicians and patients know what their targets are. So the vast majority of patients, you want good control. 7.5% is acceptable. But for your dementia patient, when you relax the target, you need a guide. So anything up to 8.5% in old money or 70 millimoles per mole would be acceptable for most of these patients. That is a safe enough threshold that you will not get the acute complications of high blood sugar, and you will not get the long-term complications that you will get with intensive control as well.
What have you encountered in your practice in terms of families who maybe have misunderstood the rationale for doing that?
I think it's about explaining the goal of treatment to the families. So, like you said, for younger patients, safety is probably not a major goal of treatment. The major goal of treatment for younger patients is avoiding long-term complications of diabetes. You don't want somebody in their 40s develop heart attacks and strokes. But if you are elderly frail in your 90s, a lot of the time you have several other medical problems, long-term conditions you are living with, and the quality of life is so poor that most patients will just say, you know what, I've had a good life. I just want to be safe now. I have a good life and maintain my good quality of life. If there is heart attacks and stroke, I pray I don't get that. But if it does happen, most of these patients would have discussed with their GPs to do care plannings, so they have a process in place for them not to be resuscitated. So for somebody like that, you want to keep them as safe as possible, and the focus on avoiding complications in the long term is not so much a problem because they don't have long to live anyway, and these complications tend to develop several years of intensive control. So the focus is slightly different. So if you explain this to the carers and they grasp the concept that at that age, the focus is patient safety rather than avoiding long-term complications, then it will make sense for you to, working with them, successfully reduce some of the medications that are prescribed to prevent long-term complications, but may actually inadvertently lead to side effects that could compromise the safety of the patient, such as falls, low blood pressure, confusion.
Yeah. So it's really important to make that absolutely clear, that when you're in your 30s and 40s, the long-term complications that we're trying to avoid are things like the heart attacks, the strokes. And when we say long-term, we mean developing over 5, 10, 20, 30 years, which obviously when you're 30 and 40, life expectancy is likely to, you can easily live for that. And we want you to live healthily for at least that time period. If you're in your 80s, the chances of you living for 30, 40 years are obviously reduced. So we're trying to reduce, obviously, things like heart attacks and strokes. Still, we don't want that to happen to people, but it's more about shorter term, let's say. So things like very low blood glucose, which can put you at risk of things like irregular heartbeats or falls, which can cause other problems, other harm to you, is really what we're trying to avoid. So then the HbA1c doesn't have to be as tightly controlled as it was previously, and that's the way that we're trying to keep you safe. It's not that people are giving up on your care. It's about your care is going to look different. I mean, it's a bit like, as I was saying earlier, as we get older, we have grey hair and we look different, and sometimes our care is going to look different as well as we get older, to keep us safe. So yeah, it's really important to have those discussions, be transparent, be clear with that person living with diabetes and dementia and their caregivers as well. And yeah, it's just so nuanced in terms of the care, because everybody's so different, that with some people it will be the family who may then need to take over, if I can call it, the administration of the diabetes care, whereas previously the person themselves used to do that.
Yeah, I totally agree with that. Yeah. At that age, the carers have to have a lot of input to keep them safe. Yeah.
But also being mindful of trying to maintain that person's dignity, the person who's living with diabetes and dementia, trying to maintain their dignity and remember that they do still have autonomy to some differing degree, and that will depend on how their dementia and their diabetes is impacting their health at the time.
So vascular dementia is different. It's a type of dementia that happens because of diseases with the vessels in the brain. So for somebody who's got a stroke, for example, when they recover from their stroke, their chance of getting dementia following the stroke increases, and that's vascular dementia. So your dementia in this case is not to do with the cause that I talked about, insulin resistance and tau bodies and inflammation in the brain. No, that's not what is happening here. This is just because of poorly controlled diabetes or hypertension, you get a stroke, and because of that, you end up with memory impairment later on. And this type of dementia tends to be less common, even though it happens. And its progression tends to be more stepwise, but it can also be prevented by using what I would call in medicine secondary prevention. So if you had your stroke, the doctors will normally have you taking your statins and your clopidogrel and your blood pressure control, you quit your smoking, all those usual risk factors. If you control them, then you prevent yourself getting a recurrent stroke, and indeed reducing the risk of worsening of memory impairment. So that, in a nutshell, is what the vascular dementia is. Dementia that is caused by problems with your vessels in the brain.
And Sam, can we just clarify also that you can have vascular dementia, so that dementia that is caused as a consequence of having problems with your blood vessels and your circulation, you can have that just unfortunately be at risk of that by living with diabetes, but without having a stroke. You can still be at risk of developing vascular dementia. So not only in the context of having a stroke, but also living with diabetes can increase your risk of developing that vascular dementia. Yeah? Okay. All right. But I'd now like us to move on to what we can do to try to avoid it. You highlighted some things for particularly the African Caribbean populations, how we could, the major factors for those populations, how we can avoid, what we can avoid in terms of the risk of developing dementia if we're living with diabetes. And general risk factors now. So for the entire population, what other risk factors? You've mentioned things like smoking. You've mentioned things like stroke. You've mentioned other risk factors, hearing loss as well, you mentioned. Would you be able to say a few words about those other risk factors? Because I think we always try and give people an idea about what they could possibly do to avoid a condition if possible?
Yeah, so what I was saying, Joan, was that that study that was recently published looked at patients with dementia and looked for the risk factors, and they found there were 12 risk factors that accounted for about 41% of all the cases of the dementia. And these 12 risk factors included things like depression, social isolation, diabetes, air pollution, physical inactivity, smoking, obesity, excess alcohol, hypertension, hearing loss, and poor level of education. And these were all together contributing to the 41% of all the cases of dementia. Now, within this risk factor profile, what they found was that a decrease in 50% risk of each of these led to a reduction in about 7% of the risk of developing the dementia, which is good. And indeed, what they also found was that there were some of the risk factors that were more associated with the risk of dementia, far more than others, especially in certain ethnic groups. And those were things like hypertension in the Black population, obesity, physical inactivity, and indeed diabetes. So controlling this would actually not just help with your diabetes, but will also help reduce your risk of developing dementia.
And two other things that I wanted to highlight from that study and other studies as well. And I think we've really seen this manifest over the past couple of years with the pandemic, social isolation and depression. And I think two things to perhaps highlight from this is that depression can sometimes mask and manifest itself as somebody might be suffering with dementia, but actually it could be depression. So as clinicians, we're always tasked with trying to exclude any other cause for somebody's what we call cognitive decline. So depression is something that we have to exclude, certainly. And I noticed in family members the social isolation of lockdowns has reduced people's ability, their functional ability. So that may include things like memory. It may include things like ability to do things that they used to do. And for somebody who may be frail and elderly, that may be something that is now manifesting itself and looking more like something like dementia. So it's really important, as well as being really careful about your weight, not smoking, keeping your blood pressure as it should do, that we make sure that we have social interactions as well. So that is a really important way to reduce one of the risk factors for developing dementia in future ages. So I want to thank you very much, Professor. Is there anything you wanted to leave us with as tips, and also anything you want to highlight to us in conclusion?
Yes, in conclusion, Joan, I just want to highlight that there is an interaction between dementia and type 2 diabetes, and it's through the insulin resistance angle. And we can do something about the diabetes by getting physically active, and controlling all the other risk factors that are associated with poor outcomes in diabetes. You've mentioned social isolation, which is good. Control your blood pressure and reduce your weight. These we can do things about. And if you do that, you control your diabetes and you will help with the insulin resistance and thereby help with your risk of developing dementia.
That's wonderful. Thank you so much, Professor. Really, really grateful to you.
Thank you very much, Joe.